Hey, welcome to the Memorizing Pharmacology podcast. What I wanted to start with was a Pharmacology Basics, just an overview of many of the concepts that you'll need to know, and it's set up as a fill-in-the-blank. So it starts with an introduction, then we'll talk a little bit about drug regulation and development, a little bit about trials and how a drug makes it to market, about drug names and difference between generic and brand. Then we'll go into a little bit of depth of pharmacokinetics, which is the four basic principles: the absorption, the distribution, the metabolism, the excretion. Then pharmacodynamics, how these drugs interact with receptors and things like that. Then some kind of drug interactions that we can have. And then some adverse drug effects. And then how individually we react to medicines. But again, it's just a 45-minute brief overview of pharmacology. I hope you enjoy.
Hello, today we're going to talk about some fundamental concepts of pharmacology. We're going to talk about the history of drug development and drug regulation, the different names of drugs. We'll introduce the concepts of pharmacokinetics and pharmacodynamics. We'll talk about how drugs can interact with each other and the adverse effects they can have. And finally, the individual responses to medications. Before we get started, I want you to think of these three terms. We'll talk about each of these concepts in more detail as we move along. There are three important characteristics of every drug. The first is effectiveness. Effectiveness is whether or not a drug has its response that it is intended to, or how well the drug works. It is considered the most important characteristic of a drug, because if it doesn't do the job it's supposed to, what is the point in giving it? The next characteristic is safety, or whether or not a drug produces harmful adverse effects. It's impossible to eliminate all adverse effects of a drug, so drugs are considered in terms of risks and benefits. Chemotherapy, for example, always comes with an increased risk of infection when given in high doses, and a drug even as safe as aspirin also has its own adverse effects. Long term, it has the risks of gastric bleeding and ulcers. And finally, selectivity. Selectivity means that a drug only has the effect that it is intended to, or it only acts on its target. It's important to remember that all drugs can cause side effects and none are completely selective. To get started, I would like to talk about some history of drug regulation and development. In 1906, the first law regarding drug regulation was passed. The Federal Pure Food and Drug Act of 1906 set quality and purity standards. And then in 1938, the Food, Drug, and Cosmetic Act regulated drugs based on their safety. Diethylene glycol, the ingredient in antifreeze, was used as a solubility agent in an antibiotic and more than 100 people died. So the FDA decided that drugs must be deemed safe before they would gain approval from the FDA. Then in 1962, the Harris-Kefauver Amendment was passed, stating that drugs must be proven effective as well as safe. The events leading up to this happened mostly in Europe, where thalidomide, a sedative, was being used by many women to treat morning sickness. The drug ended up causing birth defects and fetal deaths. Thalidomide was never approved in the U.S., but it did spur the FDA to want stricter requirements for drug approval. In 1970, the Controlled Substances Act created rules for drugs that have a potential for abuse. The next law I'd like to talk about is the 1992 Prescription Drug User Fee Act. It allowed for accelerated approval of new drugs for AIDS and cancer. The FDA takes a very long time to approve drugs, and medications were needed quicker than that process allowed for these serious illnesses. In 1997, the FDA Modernization Act expanded this to cover other serious illnesses and created other rules regarding clinical drug trials. Drug companies test their new medications through randomized control trials. The use of controls help researchers determine how new drugs compare to either existing treatments or no treatment. This is done by comparing the new drug to a placebo or to another existing medication. Randomization prevents allocation or selection bias. This keeps researchers from putting sicker people in the placebo group and trying to purposely assign people to make the groups appear the same still has challenges due to unknown factors. Randomization controls for both known and unknown factors. This helps ensure members of each group are similar and that the outcome will more likely be the result of the treatment instead of the differences between the groups. To minimize personal bias, subjects are blinded. By being blinded, the people involved in the trial can't use their own biases or judgments to determine how they think the treatment affected them. A double-blind experiment is when both the subjects and the researchers do not know who received the treatment or the placebo. Groups are treated the same, and the placebo is usually matched so that it appears identical to the treatment. It's revealed at the end of the trial who was in each group. There are different stages to drug testing. Before new drugs can be tested on humans, preclinical testing must be done. Preclinical testing looks at the potential useful effects, the toxicities, and the pharmacokinetics of new medications. Only after preclinical testing has been done will the FDA award a drug with an investigational new drug status. Once a drug enters clinical trials, there are different phases that it must go through. First, in phase 1, healthy volunteers are used to test the drug's metabolism, pharmacokinetics, and potential effects. Then a drug moves into phase 2, where the patients who have the condition that is being treated are used to test to determine the best dose and therapeutic uses for the drug. In phase 3, patients with these conditions are used to test the drug for safety and effectiveness. The drug then is approved and goes to market, but it is not done with its testing. Phase 4, post-marketing research, is done to continue to monitor for safety and effectiveness in the general population. Some adverse effects may not be seen in the clinical trial populations, so post-marketing research continues to monitor the drug over time, as it is used in a larger group of people. Next, I want to talk about the different names that drugs can have. Each drug has a chemical name, generic name, and trade or brand name. The chemical name tells you about the drug's chemistry. For example, the chemical name for Tylenol is N-acetyl para-aminophenol, which is long and complicated. The trade or brand name is owned by the drug manufacturer and is used for marketing. Sometimes drugs are referred to as their brand names because they are easier to pronounce. But the best name to use for a drug is its generic name. A drug's generic name often contains a stem to tell you which class it belongs to. The generic name for Tylenol is acetaminophen. A generic drug for low pressure is metoprolol, and it contains the ending olol, which gives you the clue that it is a beta blocker used for hypertension. In order for a generic to be considered equivalent to the brand name, the drug and dose must be exactly the same. However, inactive ingredients may differ, which can have an effect on the drug's absorption. For some medications, this little difference can have a big effect. For some medications, a slight increase in absorption can lead to the drug being toxic or not safe, and a slight decrease in absorption can make it so that the drug is no longer as effective. An example of a medication that we should be cautious with when switching between brand and generic, or even between two different generic manufacturers, is Synthroid or levothyroxine. Next, I want to talk about pharmacokinetics. As you may guess by the ending kinetics, pharmacokinetics talks about how drugs move throughout the body. There are 4 basic principles of pharmacokinetics, and they can be remembered by the acronym ADME. A for absorption, D for distribution, M for metabolism, and E for excretion. Absorption is how a drug moves from the site of administration into the blood. Sites of administration could be orally or intravenously, or other administration modes, which we will talk about later. Distribution, then, is how the drug moves throughout the body, how it gets to its intended target. Metabolism is the biotransformation of the drug, or how it is changed. Excretion is how the drug exits the body. When talking about routes of medication administration, there are 2 broad categories it can fall into: enteral, or using the gastrointestinal tract, or giving medications orally, and parenteral, or going outside of the GI tract, which usually refers to medications that are given by injection. Parenteral routes of administration include intravenously, or IV, intramuscularly, or IM, or sub-Q, subcutaneously, or under the skin. When a drug is given intravenously, or by IV, the absorption is almost instantaneous, because if you remember from above, absorption refers to how the drug moves from the site of administration into the blood, and IV administration injects the medication directly into the vein, or into the blood. Because the absorption is 100%, IV administration is best for use in emergency situations when drugs have to work quickly. However, IV medications can be expensive, and they're inconvenient for the patient to treat themselves at home because IV medications must be given by trained medical professionals. The route of administration that is most convenient for the patient, and usually the least expensive, is enteral, or oral, or PO. However, some medications can be inactivated by oral administration, and oral medications have variable absorption. Enteral medications usually come in tablet or capsule form. There are some preparations that can be made to give the drug different properties. Enteric coatings are used to allow a drug to pass through the stomach and into the intestines. Enteric coatings have 2 different intended effects. Enteric coatings can be used to protect the drug from the stomach so that it doesn't dissolve or become inactivated before it reaches the intestine, and they can also be used to protect the stomach from the drug, as is the case for enteric-coated aspirin, to help prevent against gastric ulcers. To allow a drug to achieve more steady levels over time, sustained release preparations are used. Sustained released or extended released preparations have an advantage in that this allows medications that may have needed to be taken many times throughout the day to only be taken once or twice daily with a sustained release preparation. Once a drug has gotten into the blood, it must be able to exit the blood and reach its intended target. Medications need to move through the blood to the tissues, exit the vasculature, and then enter the intended cells. Some medications need to get into the brain or into the CNS system. In order to enter the CNS system, medications must be able to move through the blood-brain barrier. Drugs that are lipid-soluble can more readily cross the blood-brain barrier. Also, drugs that are lipid soluble are more likely to enter the placenta. Some medications are harmful to the growing fetus, and this lipid solubility would be a bad factor in regards to its ability to cross the placenta. The next two pharmacokinetic principles are metabolism and excretion. The liver is most often responsible for drug metabolism, and most excretion is done by the kidneys. When drugs are administered orally, they are absorbed from the gastrointestinal tract and transported to the liver. Some medications are rapidly metabolized by the liver and can undergo what is known as the first-pass effect. Drugs that are rapidly metabolized can be inactivated and then have no therapeutic effect. To bypass the first-pass effect, medications are often administered parenterally so that they are not transported to the liver. Another example of a medication that avoids the first-pass effect is sublingual nitroglycerin. When nitroglycerin is administered sublingually or under the tongue, it is readily absorbed into the bloodstream and carried to the site of action instead of through the gastrointestinal tract and into the kidney. In the liver, many drugs are metabolized by cytochrome P450 enzymes. Medications can be either CYP or cytochrome P450 substrates, inhibitors, or inducers. Drugs that increase the rate of metabolism are called inducers, and drugs that slow the rate of metabolism are called inhibitors. If the metabolism of a drug is induced, it means it'll be broken down quicker, and the dose would need to be increased to have the same effect. If the metabolism is inhibited or slowed down, that can lead to drug accumulation, which can increase toxicity and adverse effects. Most drugs are excreted or exit the body by the kidneys through urine, but there are other ways that drugs can be excreted from the body. A drug can leave the body through sweat, saliva, bile, breast milk, and even by exhaling air. These four principles, absorption, distribution, metabolism, and excretion, all play a part in determining how long a medication will be at its intended target. It is nearly impossible to measure the concentration of a medication at the intended target, so plasma drug levels are drawn to determine whether or not a medication falls within the therapeutic range. There's a direct correlation between toxicity and effect and the plasma concentration. The therapeutic range refers to the range of plasma levels that are present when a drug is effective without producing toxic effects. Most medications are not given in a single dose. Instead, multiple doses are given over time. So one important concept that we must look at is the half-life. The half-life is the time it takes for half or 50% of the drug concentration to leave the body. The half-life is used to determine how frequently a drug is dosed. Also, the half-life is important in determining how long it takes medications to reach a steady state or plateau in the blood. Drug concentrations will reach a steady state after approximately 4 half-lives. One way to help a drug reach steady levels faster is to give a loading dose, or a larger dose of medication. The loading dose does not have a different half-life, there's just more of it. So when half of the original dose is gone, the concentrations are still higher in the blood. Now that we've talked about pharmacokinetics, let's move on to pharmacodynamics. Pharmacokinetics is the concept of what the body does to drugs whereas pharmacodynamics is what the drugs do to the body, or the effects that they have. There's a dose-response relationship that allows us to individualize medications for patients based on the desired response. Two concepts related to the dose-response relationship are maximal efficacy and relative potency. Maximal efficacy refers to the greatest effect a drug can produce. For example, morphine has a greater efficacy in treating pain than acetaminophen. That means that it can treat more intense pain than acetaminophen can. Relative potency is a measurement of how much of a drug is needed to have the desired effect. One example of this is two different diuretics, bumetanide, which is dosed in 1 or 2 milligram doses, versus furosemide, with a normal dose between 20 and 40 milligrams. The important thing to remember with potency is that a drug that is more potent doesn't necessarily mean that it's more effective. It just means that you need less of a dose to have the same effect. I've talked a lot about drugs needing to reach their intended target. Oftentimes that target is a receptor. A receptor is a special chemical binding site where a drug acts. Think of receptors in drugs as a lock and key, or puzzle pieces, where only certain drugs or substances will have the correct properties or characteristics to bind with certain receptors. Receptors also act with endogenous substances in our body. These are things like neurotransmitters and hormones that are already endogenous or living in our system. Drugs are selective for certain receptors, and if a drug is more selective, it will have fewer side effects. Drugs can have one of two different effects at a binding site or a receptor. They can either be an agonist, where they mimic the actions of endogenous substances, or an antagonist, where they block the receptor and prevent their activation. So these antagonists block the action of the endogenous substances in our body, like neurotransmitters and hormones. Agonists have a high affinity for receptors and have intrinsic activity, whereas antagonists have no intrinsic activity. They are only blocking the activity of other substances. Affinity is the strength of attraction between the receptor and the drug or endogenous substance. Intrinsic activity refers to the drug's ability to activate the receptor. This is why antagonists have no intrinsic activity. In addition to being an antagonist or an agonist, drugs can also be partial agonists. This means that they do not have as strong of an effect as a full agonist. Drugs that are partial agonists can also have some agonist and some antagonist activity. It is also important to note that some medications do not act through receptors, but rather produce their effects through physical or chemical properties. One example of this is antacids that work to neutralize stomach acid rather than on certain receptors. Earlier we talked about the therapeutic range. A similar concept in pharmacodynamics is the therapeutic index. During clinical testing, the ED50 and the TD50 are determined. The ED50, or effective dose 50, is the dose where 50% of patients achieve the desired or therapeutic effect. The TD50, or toxic dose 50, is the dose where 50% of the patients had an undesired toxic or side effect. The therapeutic index is the range in between the ED50 and the TD50. It's defined by the TD50 over the ED50. The image to the right shows two different dose-response curves to represent the therapeutic index. On the left, you'll see a bell curve where the number of patients who achieved the therapeutic effect and the number of patients who had toxic effects at different doses. The green line in between represents the therapeutic index. On the right, there is another way to look at it, where the percentage of patients are plotted against the dose. And you can see the ED50 and the TD50, where 50% of the patients achieved either the therapeutic response or the toxic response. In row A, we see a medication that has a more wide therapeutic index compared to row B, where the medication has a narrow therapeutic index. We can see in row B that the therapeutic effects and the toxic effects can overlap in drugs that have a narrow therapeutic index. This is why drugs with a narrow therapeutic index are more dangerous and levels need to be monitored more closely. Let's take a moment to look at a hypothetical example to help illustrate the therapeutic index. Let's imagine that drug A represents an analgesic where the ED50 is equal to 200 milligrams and the TD50 is equal to 2,000 milligrams. 2,000 divided by 20 would give us a therapeutic index of 10. On the other hand, let's imagine that drug B represents a blood thinner where the ED50 is 5 milligrams and the TD50 is 20 milligrams. 20 divided by 5 would give us a therapeutic index of 4. 4 is smaller than 10. Drug B has a more narrow therapeutic index than drug A. Up until this point, we've talked about the effects of drugs and how they act individually. But patients are rarely on only one drug at a time, and drug interactions is an important concept that we must talk about. There are 3 ways drugs can interact with each other. They can intensify the effects of each other, one drug can reduce the effects of another, or the 2 drugs, when taken together, can produce a brand new response. When 2 medications intensify their effects, this is known as a potentiative interaction. Potentiative interactions can be either good or bad, that is, beneficial or detrimental. An example of a beneficial potentiative interaction is the use of clavulanic acid with amoxicillin in the antibiotic Augmentin. The clavulanic acid increases the effects of amoxicillin, so this is a beneficial or good potentiative interaction. The 2 medications work together to intensify their effects. An example of a detrimental potentiative interaction, on the other hand, is when a patient takes both warfarin and aspirin. Both of these medications have a risk of bleeding, and taking them together increases that risk, so it potentiates the risk. And since we're talking about adverse effects, this is detrimental. When 2 medications interact to reduce the effects of one or another medication, this is an inhibitory interaction. Like potentiative interactions, inhibitory interactions can be either beneficial or detrimental. An example of a detrimental inhibitory interaction is when a patient who has asthma and is taking albuterol starts taking propranolol. Propranolol is a beta blocker, and it can interact with receptors in the lungs, which is where albuterol works. So the propranolol inhibits the effects of the albuterol. On the other hand, a beneficial inhibitory interaction could be when naloxone is used to reverse respiratory depression in an opioid overdose. The naloxone is used to inhibit the opioid and stop the overdose symptoms. An example of an interaction that produces a new response is when metronidazole, an antibiotic, is taken with disulfiram. Disulfiram, or antabuse, is used to treat alcohol abuse. When a patient drinks alcohol while taking disulfiram, they become violently sick. A patient who is taking metronidazole, who drinks alcohol, would have that same disulfiram-like effect. While those two medications typically would not produce that response on their own, when the alcohol is taken with metronidazole, they will become violently ill. Another way that some medications can interact with each other is through chelation. Some medications, like ciprofloxacin, can bind to metal ions such as iron, calcium, and magnesium. When the ciprofloxacin binds to these heavy metals, that is called chelation, and that is why some antibiotics should not be given within a few hours of multivitamins or antacids, especially those that contain magnesium, calcium, or aluminum. Drugs not only interact with other drugs, but they can also interact with food. So does food increase or decrease drug absorption? The answer is either. It depends. Some medications are best taken on an empty stomach. For example, alendronate, a drug used for osteoporosis, is almost completely non-absorbed when taken with food. Other medications, such as metoprolol, are best taken with food to increase drug absorption. An important drug-food interaction is grapefruit juice. Grapefruit juice is an inhibitor of CYP3A4 and can slow down the metabolism of many drugs, including simvastatin and amlodipine. Because metabolism is inhibited, the peak effects of these drugs will increase, which could lead to increased adverse effects. Now we will move on to adverse drug reactions and medication errors. An adverse drug reaction is an unintended, undesired effect when a drug is given at normal doses. We're going to define some terms related to adverse drug reactions. First, we'll start with the most commonly known, the side effect. A side effect is a virtually unavoidable effect at intended doses. An allergic reaction is an immune response that occurs after the body has been re-exposed to a drug. Toxicity is the harmful physiological effects at excessive doses. An example of toxicity is when a patient has life-threatening hypoglycemia or low blood sugar after an overdose on insulin. Iatrogenic disease may be a new term for you. Iatrogenic disease is a disease caused by drugs or medical treatment. An example of this is patients who are taking antipsychotic medications may develop Parkinson's disease-like symptoms due to the medications that they have been taking. Side effects are usually predictable, but an idiosyncratic effect is unpredictable. An idiosyncratic effect is an uncommon reaction that is due to a person's genetics. Two very specific types of effects are carcinogenic effects and teratogenic effects. Carcinogenic effects are cancer-causing effects of drugs or chemicals. Teratogenic effects refer to birth defects caused by medications. Lastly, a paradoxical effect is a response that is opposite of what is intended or expected. An example of this is when Benadryl, diphenhydramine, is given to young children. Diphenhydramine typically has a side effect of causing drowsiness, but when it's given to young children, it'll have a paradoxical effect of causing excitement or hyperactivity. Adverse drug reactions can also be organ-specific. One important organ, due to its relationship with drug metabolism, is the liver, so we should be aware of medications that can cause hepatotoxicity, or liver toxicity. Another important adverse drug reaction that we need to discuss is QT prolongation. The QT interval on an electrocardiogram measures the time it takes for the ventricle of the heart to repolarize after each contraction. QT prolongation can cause fatal dysrhythmias, specifically torsades de pointes. The FDA requires that all new drugs be tested to see if they cause QT prolongation. Currently, over 100 drugs are known to cause QT prolongation. When two medications that can both cause QT prolongation are given together, this needs to be addressed. An example of this is when levoquin, or levofloxacin, is given to a patient who is on escitalopram, an SSRI used to treat depression. In this case, we would discuss with the patient's doctor about changing the antibiotic to one that is not known to cause QT prolongation. We would not want to change the patient's antidepressant therapy, and the antibiotic is only given for a short time, so that is the medication that we would want to have changed. Medication errors are a major cause of patient injury and cost billions of dollars each year. A medication error is defined as any preventable event that may cause or lead to inappropriate medication use or patient harm. Anyone involved at any step of patient care can potentially make a medication error. The Institute of Medicine has identified 3 main categories as causing 90% of all medication errors. These are human error, communication mistakes, and drug name confusion. All healthcare providers must be aware of the types of medication errors that can occur and the events that lead up to them, so that everyone can be vigilant in preventing medication errors. It is important for all hospitals and other institutions to adopt a culture of safety. Other measures that have been taken to reduce medication errors include using barcoding systems to scan patients and medications. Also, replacing handwritten medication orders with computerized order entry. Another measure that has been taken to reduce medication errors and prevent adverse reactions is medication reconciliation. Medication reconciliation is done at transitions of care where the nurse, pharmacist, or other provider compares the list of medications that a patient was taking prior to admission or discharge to the list of current medications that they are taking while in the hospital or when they leave. Even when we know the pharmacokinetics and pharmacodynamic properties of medications and how these drugs can interact with each other, medications can still have an individual drug response that can vary from individual to individual. Factors that can have an effect on drug response in individuals include weight, age, gender, race, and genetics. Some medications need to be adjusted for body weight in order to have the intended effect. Some medications are even dosed based on body surface area because body fat percentage can change the way drugs are distributed in the tissues. One example of a type of medication that is commonly dosed based on body surface area is chemotherapy for cancer. Age affects the way that drugs can respond in individuals. Patients who are very young and very old can have increased toxicity with certain medications. Those who are very young have immature organs, and those who are very old, their organs are starting to wear out, and so they do not metabolize drugs as effectively as before. An example of how drugs can affect gender differently is alcohol. Females metabolize alcohol slower than males and therefore get intoxicated faster. Race is another factor that can alter individual dose response. One example of how race can affect drug response is with ACE inhibitors, like lisinopril, used to treat hypertension. Studies have found that ACE inhibitors are not as effective in African Americans. Also, people with Asian ancestry may have a gene for HLA-B1502. Individuals with this gene have been found to have a serious adverse skin reaction when they take carbamazepine, a drug used for epilepsy. We are learning through pharmacogenomics that genetics can play a big role in how individuals are affected by different medications. One example of this is with the drug trastuzumab, which is used for breast cancer. Trastuzumab is only effective in treating breast cancer that is positive for the HER2 gene, HER2. This is only one example of how genetics can affect individual drug response. Comorbid conditions are another factor that can affect individual drug response. For example, patients with liver disease and kidney disease can have different effects on drug accumulation because of these organs' roles in metabolism and excretion. Therefore, patients with liver or kidney impairment will need doses of their medications reduced to avoid toxicity. In addition to liver and kidney disease, acid-base imbalance, or your body's pH, and electrolyte imbalance are two other ways that patients can be affected by individual drugs. Digoxin is an example of how electrolyte imbalance can affect drug response. You should monitor potassium levels in patients receiving digoxin to reduce the risk of dysrhythmia. Individuals can also develop tolerance to medications. That is, they have a decreased response or require increased doses to have the same response. There are different types of tolerance. Pharmacodynamic tolerance develops over long-term use. Higher doses of a medication are required to have the same desired response. Metabolic tolerance, on the other hand, is due to rapid metabolism of medications, meaning higher doses of a medication are required to maintain consistent plasma levels to keep the medication within the therapeutic range. Tachyphylaxis is a phenomenon where your body's defenses build up quickly and stop responding to a medication. So when repeated doses of a medication are given in a short time frame, the body reduces its response. Another term that isn't exactly related to tolerance is the placebo effect. The placebo effect is a psychological response to a drug independent of the biochemical actions of the drug. The placebo effect is neither a good or a bad thing. It's been found that nearly all drugs have at least some degree of a placebo effect. What this means is that attitude is everything. Sometimes just because a patient thinks a medication is working, it actually is. On the other hand, if you take a medication and think it's not going to work, it may not have its intended response. Even if a patient is only taking a medication for a placebo effect, it shouldn't necessarily be discontinued, because if they think the medication is going to help, it can speed recovery. I hope this review has given you a better understanding of the fundamental principles of pharmacology. Thank you for listening.